I've always been more of a continuation maintenance person, even before we had all the trial data, so perhaps I was biased. But I've tended to use drugs that I know I can continue. So for the squamous patients, again, I have very few. I've been a big fan of gemcitabine and continuing that. For my patients with non-squamous disease, I still use pemetrexed up front quite a bit, sometimes still with bevacizumab, and then I will continue with those drugs. If it's a patient where we've decided we're going to go with a taxane, and I'm going with the platinum taxane, and with bevacizumab, I will continue the bevacizumab by itself. And if it's a patient who is getting a platinum taxane without bevacizumab, I haven't had as many of those to say I have a standard approach, but we will talk about a switch maintenance there. I never try to go beyond maximum 6 cycles with a taxane because of the toxicity. So that's really been my pattern, and Point Break, I do consider giving a carbotaxane bevacizumab regimen much more now. I had very much moved into the pemetrexed, but most of my patients who get that regimen get it in the context of a clinical trial, so then that's an easy answer to that question. It really depends on the patient. So I don't have very many who get a chemo break anymore after we've seen all this good maintenance data. There are some. And the ones who do, I will see back usually once a month just to sort of check in on them, make sure they're doing okay. And I'll get scans at least initially every 2 months. I'll spread that out to 3. But that's just not my standard practice. I really do almost always have some form of continuation maintenance.